Bipolar disorder carries a staggering mortality risk. Compared to the general population, the suicide rate among individuals diagnosed with bipolar disorder is 10 to 30 times higher. Yet, despite these stakes, this condition is frequently misdiagnosed in clinical settings. Patients are often categorized under other labels, most commonly unipolar depression, attention deficit hyperactivity disorder, or cluster B personality disorders. This happens because practitioners often evaluate a cross-sectional snapshot of the patient, treating the specific symptoms present in the room that day, rather than examining the patient's longitudinal history over years or decades. This creates a highly dangerous pharmacological trap, particularly when bipolar depression is mistakenly treated with standard typical antidepressants, like SSRIs, or even over-the-counter supplements like St. John's wort. Because bipolar depression is neurochemically distinct, introducing an antidepressant without an accompanying mood stabilizer can violently trigger an acute manic episode. Preventing these adverse reactions requires a rigorous disentanglement of overlapping symptom profiles, mapping the exact underlying neurobiological state driving the patient's behavior. Differential diagnosis in bipolar disorder is an acute, life-saving clinical imperative. To isolate bipolar depression, we start with the baseline threshold for a major depressive episode, an overwhelming feeling of depressed mood or apathy lasting for at least 2 consecutive weeks. From there, the patient must exhibit at least 5 secondary symptoms. These are often tracked using the clinical mnemonic C-GASP-DIE, covering concentration loss, guilt, appetite and sleep changes, psychomotor agitation, death ideation, lack of interest, and energy loss. The core diagnostic challenge is that these exact symptoms overlap heavily with entirely different conditions. This chart compares apathy and energy loss across different conditions. On the left is bipolar depression, on the right, PTSD. In bipolar depression, apathy functions as endogenous psychomotor slowing. The patient's entire system is essentially operating in slow motion. In PTSD, energy loss stems from constant hypervigilance. Now we add guilt against borderline personality disorder. Bipolar guilt presents as a flat, sustained state of worthlessness. Conversely, borderline guilt fluctuates rapidly, spiking and dropping based on interpersonal triggers and acute anxiety. Because the surface-level behaviors look identical, the clinician has to dig into the patient's specific history to uncover the functional driver behind those behaviors. And the opposite pole, mania, is defined by an elevated or severely irritable mood lasting at least 7 days, or any duration if the intensity requires hospitalization. Hypomania follows a similar pattern, but requires a minimum of only 4 days, and crucially, the patient remains clinically functional without severe impairment. The specific symptoms of mania are tracked through the DIG-FAST mnemonic: distractibility, insomnia, grandiosity, flight of ideas, goal-directed activities, speech that is pressured, and thoughtlessness. This matrix visualizes insomnia. We compare mania on the left against generalized anxiety and PTSD on the right. Patients with anxiety or PTSD suffer an inability to sleep. Their minds are locked in hyperarousal, even though their bodies desperately need rest. Manic insomnia presents as a fundamentally decreased need for sleep. We see a similar split with goal-directed behavior. Manic goal-directed behavior is driven by a search for a dopamine rush. The patient pursues extreme adrenaline-producing activities with remarkably poor judgment, seeking pleasure regardless of consequences. In contrast, goal-directed behaviors in a highly anxious patient are rigid and specifically deployed to mitigate or halt the anxiety they are feeling. They act not for pleasure, but to make the psychological pain stop. Manic impulsivity and extreme mood lability can also easily mimic the symptom profiles of ADHD or cluster B conditions like narcissistic and antisocial personality disorders. However, personality disorders represent long-standing environmental coping mechanisms, often developed in childhood in response to trauma. Mania does not function as an extreme reaction to external stress. It operates as an internally driven, unrestrained biological motor. To understand how that motor works, we have to look past the behavioral symptoms and examine the underlying neurobiological engine, the hypothalamic, pituitary, adrenal, or HPA axis. In bipolar disorder, The HPA axis dysfunction operates on a model best described as flat and furious. This graph tracks daily cortisol levels. After prolonged periods of overstimulation, the HPA axis turns down its sensitivity to protect the organism from running too hot. This creates the flat state, shown by the depleted baseline. Because the baseline is severely suppressed, the patient feels almost nothing, plunging into profound anhedonia. But when a sufficient brick tierces that down-regulated system, it overreacts violently, entering the furious state. The body is flooded with excessive cortisol and adrenaline. The system goes from entirely numb to completely terrified or manic, leaving zero middle ground for normal emotional regulation. This intense biological stress triggers severe downstream effects, including severe circadian rhythm dysregulation, elevated oxidative stress, and chronic inflammation throughout the brain and body. Bipolar mood swings and the outward behavioral symptoms of a violently dysregulated neuroendocrine system. This biological reality proves why cross-sectional diagnosis fails. Clinicians must construct a longitudinal map of a patient's entire lifetime episodic history. This timeline maps clinical episodes over years, allowing us to identify 3 primary diagnostic typologies. A single massive manic spike on this timeline confirms Bipolar I, even if no depressive episodes are present. Bipolar II features hypomanic and major depressive episodes. Cyclothymia involves hypomania and dysthymia for over 2 years. A common misconception is that cycles swing like a clean pendulum from depression to mania. The reality is highly unpredictable and chaotic. Patients experience mixed episodes with elements of both poles simultaneously, or rapid cycling, where 4 or more distinct mood episodes occur within a 12-month period. The most dangerous clinical blind spot lies in euthymia, the supposedly asymptomatic spaces between major episodes. Outside of a full episode, patients endure heavy subclinical mood lability and sleep dysregulation during these periods. The window of highest clinical danger occurs right as a patient emerges from a depressive episode. Their physical energy returns before their depressed mood and suicidal thoughts lift, creating a lethal combination. An accurate clinical map of the disorder must account for the chaos of mixed episodes and the hidden dangers lurking within recovery and euthymia. While primarily identified through psychiatric symptoms, bipolar disorder is a systemic physical illness. Individuals with bipolar disorder face exceptionally high rates of severe physical comorbidities, most notably cardiovascular disease and type 2 diabetes. These outcomes are directly driven by chronic HPA axis dysfunction and persistent oxidative stress, and lifestyle self-medication strategies, like poor diet and substance use, that patients rely on to endure extremes. There is also a high co-occurrence with polycystic ovarian syndrome. Extreme fluctuations in gonadal hormones directly impact the availability of vital neurotransmitters like serotonin and norepinephrine, triggering further episodes. Effective management requires a strategy that addresses the body's entire physiological state, rather than simply matching a psychiatric drug to a specific mood. A robust treatment plan integrates chronobiological strategies to regulate sleep, aggressive stress management, and the development of functional self-efficacy. By accurately disentangling bipolar disorder from its mimics, clinicians provide patients the exact foundation needed to manage a systemic illness and build a meaningful life.